So Dr. Verma was speaking mainly for the
Put it on the slideshow, Mallika.
Yeah. Dr. Verma was speaking for surgeries, and I'm going to speak for OPDs. That is how we had divided the topics. So what we have to understand is that all these changes are not going to be for a 1 month, 2 months, 3 months. We are looking at over a year, because the risk of this virus spread is not going to go away when the lockdown is eased. It will go only when there is a vaccine, and that vaccine has not even been possible for SARS and MERS yet. So we don't even know that there will be a good vaccine. And herd immunity as a concept does not apply here because of its morbidity and mortality. Even China, when they have released their lockdowns, they are seeing a second wave. And in fact, in China, a lot of patients who had recovered from the virus and had tested negative have again got the virus infection. So there's not even an immunity in a given patient, it seems. So the risk of transmission will remain high till there is a vaccine. So we are looking at all this for at least a year and maybe more. Now, we cannot go on not seeing patients because there are patients who have these problems which cannot wait indefinitely. So what we can do is, in the OPDs, we have to have a very light OP, minimize the number of patients per hour. And this we can only do by categorizing the appointments based on the urgency of the indication. So when the receptionists are giving appointments, they have to be trained to understand the urgency of the appointment and give accordingly, and take, say, for retina, not more than 4 appointments an hour. This will allow you to social distancing in your waiting lounge, no crowding. And also the waiting time for the patients will also be kept minimum, because they are exposed in the hospital area to the infection risk. And why we also need more time is because we will be spending more time per patient, because we'll be cleaning, disinfecting in between patients. So as Dr. Verma said, we may have to increase our working hours per day and work on other days as well. So as I said, we'll give appointments based on the urgency of a patient. We will be filtering the appointments. And this can happen mainly if we all shift to electronic system of appointments, so that we know what we already have for a given day and we don't crowd the patient. We can give the appointments more systematically. That has to be done now. Walk-ins have to be minimized to prevent crowding. So we will all have to have a better way of giving appointments. And then at entry, we will have to have only one entrance into a hospital system, so that there can be a screening where somebody can ask the basic questions, record the temperature. There should be a wash basin and a hand sanitizer that every patient has to take advantage of. And masks have to be given at the entrance. And a new thing which will come in the outpatient will be COVID consenting. They will have to take the risk of in contracting the infection. Otherwise, they will not be taken into the system. So disinfection between the patients will include of the slit lamp, any area where the patient has contacted, examination chair after he leaves, scleral depressors, lenses, and the optometrist will have to do the same. Assistants will have to disinfecting between the dilating drops that they keep putting to patients. So all this will increase our time per patient, and hence we need to see less patients per hour. Now, counseling and examination will change. When we are examining the patient, we may not even need the attendant in the room. And when we have seen the patient, we can have the attendant, but only one. There should be a minimum gap of 2 meters with the attendant when we are speaking to them. Speaking has to be minimized also, because that is the source for aerosols. Other option is to keep, after you have examined the patient and after a brief discussion, the further counseling can happen on a phone while the patient is in another room, or via video conferencing if you can have it. So all discussions can happen without sitting in the same room, even post-surgery counseling in the same manner. And very important is that minimizing now having these files which are running from the reception to the optometrist to the workup and the consultant. Instead of hard copies, if we can just fill up the EMR, and this is how it reaches in a soft copy to the consultant, that will minimize the transferring of the viruses through the fomites. And also the advantage is that we can generate an e-prescription from this EMR and send it to the patient's email or WhatsApp if they don't want a hard copy, and also to the hospital pharmacy, so that the patient just goes and says his ID and his prescription is ready there. Those who don't want this, of course, they can get one paper prescription also. So this is to minimize the risk of transmission of the virus. So we will have to move more and more into electronic systems. Teleconsultations will be very important for non-urgent problems. We can have a fixed time of the day where we will talk to our patients. And if they are non-urgent, we can give them an appointment after 1 month or 2 months. And we can do several follow-ups without having to see them. And this will allow revenue generation because these teleconsultation systems will have an payment built in. Thank you.